I think I'll start because then we'll have more time to discuss for the discussion at the end.
Oh yeah, please, please
Okay. Perfect.
go for it.
Great. Hi all. I'm Anay. I'm one of the neonatal consultants here at St. George's Hospital in London, and I'm going to be well. I'm going to try and say a few things which are going to be very, very controversial, and it'd be nice to see what the experience from my colleagues has been. So, I've been scanning for last 12, 15 years probably, and have come across similar scenarios as I would present, but hadn't been brave enough to do anything about it. But I'll just talk through and we build as we go along. So I'm presenting two cases to start with, and as the title says, it involves inhaled nitric oxide. And what I was hoping to do is present these two cases, share with what we did. Just a couple of slides about the evidence, and then we can have a discussion at the end. And obviously, I'll be open for any questions from you. So essentially, case one, this little one was born at 24 weeks gestation. There was a fetal hydrops because of fetal anemia, and fetus underwent a intrauterine transfusion, following which delivered at 24 weeks gestation with hydrops with birth weight of 850 grams. Had a very stormy initial course, had a candidemia in blood culture on day 4 of life, was quite sick to start with, but progressed well, and then was extubated at around 27, 28 weeks gestation, corrected gestation under steroid cover. So had been extubated for good 4 weeks before he got unwell again, with respiratory, with desaturations, bradycardia, temperature instability. So behaved like essentially a septic process. So was intubated, ventilated, was screened for infection, and was started on antibiotics. Needed some cardiovascular support in form of fluid bolus. The blood culture grew Klebsiella within 18 hours of culture being sent. Essentially, 24 hours into illness, he rapidly became unwell with hypoxic respiratory failure, was oscillated from conventional ventilation. The mean airway pressure was 17 with 100% inspired oxygen. And despite that, couldn't be oxygenated. My colleague was on, this was later part of the evening, where essentially the saturations best we got was 86 preductally and 70 postductally. This baby has had cardiac assessment in the past and was known to have a large ductal shunt. And this kid then was commenced on inhaled nitric oxide. And the feeling at that time was obviously this was sepsis, Klebsiella, and the sepsis-driven persistent pulmonary hypertension of newborn, and hence inhaled nitric oxide was started. Now, saying that there was some initial response to this intervention, so I've just put there these markers which play a role as far as the pulmonary vasospasm and dilatation is concerned, and then thromboxane, leukotrienes. These are all acute inflammatory mediators which cause coronary vasospasm, and then that leads to pulmonary hypertension. So coming back to this kid, saturations initially improved to low 90s. But this kid then stayed in 100% oxygen for next 24 hours. 24 hours later, was asked to assess. So at this time, this baby was on 20 parts per million nitric. The FiO2 was in high 90s. As I said, initially, immediately after starting nitric, we could bring down the inspired oxygen to around 60. Now, I'm talking about all respiratory optimizations. There were lots of other things done in terms of including pressure, sedation, and improvisation of synchronization. So essentially, at 24 hours later, this kid still was in around 90% oxygen. Saturations were in low 90s. There wasn't any post-op preductal discrepancy. We could ventilate this baby well, but oxygenation was a problem. As you could see on the gas there, if at all, overventilated gas. Chest X-ray, we saw earlier on, so lots of chronic lung disease changes. There was no focal pathology that could be seen. And I had received 30 mL per kilo of volume over the last 24 hours prior to the cardiac assessment, and was on dopamine of 5 micrograms per kilogram per minute, which is our standard inotrope support as a first-line support. So impression at that time is this kid who has a Klebsiella sepsis, who was probably at his peak of SIRS or just after SIRS, had persistent high oxygen requirement, who was on inhaled nitric oxide with no pre and post discrepancy. So in a way, we were kind of stuck with not much further to go on. And I'll show you the cardiac assessment. Unfortunately, we have to download on PACS, so I've not downloaded the entire study because of patient confidentiality point of view. So I've just put some relevant clips here. So this was a subcostal view. You can see the IVCs. It's not very distended, turgid. You can see actually a small area of echogenicity within liver. So this kid has had a PN extravasation in the liver during early phase that we could see there. This was again a subcostal view. You can see that IVC again is not very distended, it's draining into right atrium, and actually you can see a tip of a long line that is poking in and out there on that image. This is kind of subcostal portion, but now this baby had horrendous lung views. The whole lung was quite air trapped with hardly any windows from chest or higher above. So the apologies for the image quality, but I've just put in what we could see at that time. So essentially had a mild septal hypertrophy, which is something again we see with kids who have received steroids, steroid extubation. There was mild TR that was seen, and one just gets a feeling that possibly your intraventricular septum is going into the LV, with LV cavity being small. This is apical four-chamber view. Again, balanced ventricles. Subjectively, biventricular systolic functions appears to be preserved. The right side doesn't look that massively big on this clip. This was a TR jet, which was around 4 meters per second, making systolic pulmonary estimated pressures of around 65 plus 5, so around 70. At this time, this kid's systemic systolic blood pressure was around 85, which was invasively measured. So we were around 10-15 millimeters mercury below systemic systolic pressure. This is parasternal long axis view. Again, you can see a bit of septal hypertrophy, and again gives a feeling that the septum is probably going into your LV cavity. This was TAPSE. Sorry, I had to take the number out. So TAPSE was 11. So preserved again right ventricular systolic function there, and this is a ductal image. Now again, as I said, I didn't have any high windows. But there was a non-restrictive large ductal shunting that you could see with bit of pulmonary vegetation. This was a Doppler across the duct. So peak to peak gradient was around 2, again making your systemic and pulmonary systolic pressure difference of around 15, which is what we saw on TR. But again, the peak reaches to the baseline quite quickly. So this was what I felt at that time. We had moderate pH, moderate to severe, I mean still subsystemic. We had preserved biventricular systolic function, and there was a moderately large ductal shunt. And the impression was this was indeed a pulmonary hypertension phenotype, but the mechanism was potentially a flow-driven rather than pulmonary vasospasm, as we see quite often. It may have been different 24 hours ago, but on this assessment, that's what I felt. And this is what we did. So essentially, on x-axis is time, so it's in minutes, and on y-axis are different parameters. So your blue worm is your inspired oxygen, the gray worm is saturations, and the orange one is the dose of nitric oxide. And we actually started dropping nitric very rapidly. And it was a very instantaneous and contemporary response that we could see. As you see here, within 60 minutes, we actually stopped this nitric, and with that correspondingly, you can see your inspired oxygen coming down to kind of late high 40s, low 50s. After we stopped, it did go up for 10 to 15 minutes, but then normalized to around 40% inspired oxygen, and that effect was sustained subsequently. Which was interesting, just because I think these babies are, as we all agree, are very vulnerable, and you don't want to make major changes in terms to change or alter physiology. But this was quite impressive seeing, and I've seen in my clinical practice similar kind of picture for a long period of time, and we all feel anxious to not change anything much, just to try and maintain that stability. But this here, I think the physiology was different, and we saw a good response following an intervention. So just quick slide. I put here Ohm's law that we use to to work out essentially a pressure difference between two chambers. So as you can see here at the right bottom, your flow equals your pressure difference between two ends of pipes divided by resistance. And if you then convert that into a pressure, your pressure would be flow times vascular resistance. And the intervention that we offer has different effects. So obviously pulmonary vascular resistance, which is the commonest mechanism that we see in this case, it does help, which then helps in the end bringing down your pulmonary pressures. But as against, we know that inhaled nitric oxide would increase the flow, and if that's what is driving pressures, then your potentially pulmonary artery pressures could get worse. Now I'm saying it potentially. We saw a good temporal progress following an intervention as I described earlier on. So just putting that line, so nitric can relieve right to left shunt in PPHN, but can exacerbate and make things worse with left to right shunt with pulmonary congestion. And in a way, if you have someone who has a large ductal shunt or known to have large ductal shunt, who is needing a high inspired oxygen, one has to be cautious with the use of inhaled nitric oxide. So that was my case one. Sorry, I'll come back to questions again together for both the cases, if that's okay. And then we can discuss cases as we go along. So this was the second case. So this was a term baby who was born in Worthing, so in South England. And it was an ex utero postnatal diagnosis of the left-sided congenital diaphragmatic hernia. And essentially the anomaly scans were normal. Baby was good size, 3.8 kilos. Was on CPAP to start with because he presented as a term baby with respiratory distress, and the X-ray there demonstrated the left hemithorax full with air-filled intestinal coils. So essentially, this baby was intubated, ventilated, and was transferred to us by a transport team. The transport team had already initiated nitric oxide. So what came to us in mean airway pressure of around 15 with 90% inspired oxygen. He had an assessment, cardiac assessment on arrival to the unit by one of my colleagues, which demonstrated moderate to severe pulmonary hypertension with predominant right to left shunting through an unrestrictive duct. The plan there was then to continue a pulmonary vasodilator at the same dose. Did receive one fluid bolus at 10 mL per kilo, and the aim, the provisional plan made was that we aim for mean arterial pressure of more than 45. Now, that was the initial plan to start with. You can see an X-ray here where the umbilical lines were reasonably placed, but the left left hemithorax is full of gas-filled loops, and there was a mediastinal shift. So this baby progressed well to start with. The mean airway pressure was brought down to 12. The inspired oxygen also came down to 50%. The inhaled nitric oxide was weaned and was brought down to 15. At that time, baby was on dopamine and milrinone, dopamine for inotropic action and milrinone, again with inotropic action without chronotropy, and was progressing well. And we were hoping that we'll, in next day or so, we will try and progress to get him to theater. But he had a worsening on day 4, day 5 of life. The oxygenation got worse, went up to 90%. This is the best, so he went almost into 100% oxygen. And that was responded by different respiratory strategies. So his mean airway pressure was increased to 15. But despite that, there was no response. So SATs remained in high 80s. And as you could see, this was an X-ray at that time. And actually, this lungs look reasonably inflated on the right side. On the left side, you can see a relatively, reasonable amount of lung, and the mediastinal shift that we saw on earlier scan actually is much lesser. So really, from respiratory point of view, we had optimized this child to the fullest, and then echo was requested to try and see what's happening. I'm just changing here a bit, so I'll just put this to this slide to just talk through about the 3 points I want to make. So these are the best practice guidelines in a way. This again, they are the evidence base is quite poor in all those practices that are put in both these documents. One is which is the CDH Euro Consortium, and the other one is a Canadian diaphragmatic hernia collaborative work. And it talks about what's a good practice or what's considered as good practice, and ECMO is discussed there, and both of them agree, and I agree that there is a case selection as far as ECMO is concerned. Historically, from Georges, we didn't send babies for ECMO with diaphragmatic hernia if we couldn't oxygenate them. At the moment in London, Great Ormond Street is our is our center for ECMO, and the outcomes for ECMO with diaphragmatic hernia is 50% mortality. So half of the babies we refer do not survive. And one of the reasons for that is late referral, is having spoken to the ECMO guys at GOS. And there's always anxiety that should we hang on to these babies or should they go to ECMO center sooner or later? Second point I want to make is we do around 10 to 12 diaphragmatic hernias every year. So we've just recently looked at around 150 of babies. There are only 2 babies of those babies of that population who died after surgery. And both of them had surgery quite late. So end of 2nd week of life. Our median time of surgery is end of 1st week. So day 5, day 6, we start these babies turn around, which was not the case for this baby. At worst, this baby's oxygen index was around 30. Again, I appreciate it was a postductal oxygenation index because it was through UAC. But again, people start getting anxious, thinking that should we be thinking about whether we should do an ECMO referral or talk to them. Okay, so I'll just show you with you the echo scan for this one. So this baby was oscillated at this time, mean airway pressure of I think 14. The subcostal view, you can see obviously this kid was paralyzed, so you would probably not see that phasic appearance of IVC, but IVC looks quite turgid and distended, which may represent increase in thoracic pressure, or it may represent your hypertensive RV, but quite dilated and distended IVC, which is seen here. Again, you can see the UVC in the optimal place, UAC, and through the clip, you can see your IVC turning into your RA. This kid's echo was quite difficult because the views were quite atypical. Most of the scan was from subcostal view, as is the case with babies with diaphragmatic hernia. I don't think you can appreciate here, but if you look frame by frame at atrial level, there was a bidirectional shunting. This is apical 4-chamber view. There wasn't much TR to measure, but you can see clearly quite dominant right atrium, right ventricle, and again your intraventricular septum possibly bowing into the your LV, making your LV cavity small. This was tissue Doppler from left ventricular free wall. As you can see, sorry, you don't have an ECG trace here. I need to take it out because of patient's name on it. But you can see that your A prime is much higher, representing possible diastolic dysfunction of the left ventricle. So your left ventricle wasn't relaxing enough, and partly was compressed because of hypertensive RV. This is parasternal short axis view. Again, you can see a flattening of the intraventricular septum throughout the cardiac cycle. It's not the flattening throughout the entire cardiac cycle, but definitely in systole. And this is just a crab view looking at the pulmonary venous return. So this pulmonary venous return is quite generous, actually, coming to the left ventricle, left atrium here. Sorry. Unfortunately, the file got corrupted, so I don't have the Dopplers, pulse wave Dopplers for the pulmonary veins. But again, it demonstrated and confirmed diastolic dysfunction of LV. So the finding was moderate to severe pulmonary hypertension and impaired LV diastolic function. And again, impression here was this is a pulmonary hypertension phenotype, but possible mechanism of pulmonary venous congestion induced pulmonary hypertension. Now, most of the pH mechanisms in diaphragmatic hernia, when we talk about possible vasospasm, where nitrate would work, or reduced vascular bed, lung hypoplasia. They just have less vascular area to gas exchange. But I think this has been recognized more and more. There's tons and tons of literature about this in adult world, so as in pediatric cardiology, pulmonary hypertension, where they look at this much more closely. So this is what we did for this kit. Again, on the time here, we did wean nitric, but did quite slowly. So again, on the x-axis is minutes. On the y-axis are different parameters, and I'll put here inspired oxygen, which is this blue curve. This is saturation, which is the gray curve, and I've put here vasopressor anisotropy score, which is a validated score to objectively demonstrate what the inotrope vasopressor needs are, and they are corrected according to the dose they were on. So at this time, baby was on milrinone of 0.5, was on NORAD of 0.1, and was on dopamine of 10, and which made the scores of around 15 or 17. To start with, essentially, we started weaning the nitric, and again saw very good contemporaneous fall in the inspired oxygen till we reached to 5, and then the FiO2 went up again, and then kind of normalized following stopping or weaning rapid. Again, this weaning was done over 6 to 8 hours rather than 1 hour in the previous case, as we discussed. These were the gases, so intervention period was around this midnight here somewhere, and we could see as things progressed, your in PO2 improved over the next 10 hours. PCO2 kind of improved, and the pH got better as well. And this is a kind of a journey of this kid over kind of first 7 days. These are the best observations in 24 hours, not the worst. And so initially was in 100% oxygen, then got better around day 3, day 4, got worse again on day 4 when we did an assessment and we weaned nitric and stopped it, and actually progressed quite well. And in a baby where we were thinking that we probably need another week before we be ready for surgery, went to surgery within 48 hours and had an operation, is discharged home. So I would just like to put here this phenomenon, pulmonary hypertension induced by pulmonary venous hypertension, which is very well described. Having spoken to my adult colleagues who manage restrictive LVs or a cardiomyopathy type picture. It's an entity which is quite difficult to manage, which is quite challenging to manage. And this is a nice review article by Thomas Quillick from Boston, where they described it in great detail, and they proposed 2 primary mechanisms. I think one of the mechanisms is relevant to us, probably both are relevant to us, but we see in different populations. The first mechanism that leads to pulmonary venous hypertension is where your apparatus posed to the pulmonary vein is abnormal, meaning you have diastolic dysfunction of LV, you have mitral valve problems, you have intracardiac pulmonary vein stenosis, where essentially it will lead to back pressure changes, leading to pulmonary venous hypertension, leading to possibly pulmonary arterial hypertension. And second mechanism is pulmonary venous stenosis, but intrapulmonary pulmonary venous stenosis. So not at the ostium as it enters, but before it enters. And again, this is something which we see not uncommonly. It's well described in babies who are born extremely prematurely with severe chronic lung disease with pulmonary hypertension. There's a nice case series. I think Sujit presented one of the cases in one of these talks, where pulmonary venous stenosis is one of the causes for pulmonary hypertension, and has an intervention available for it. So these are 2 primary mechanisms that one has to think about, and I think, my opinion, this ARCADE fit into this first mechanism here. Now, second, putting to this slide, I'll put that two studies here. I think the first study is where this asks question whether even if you have pulmonary venous hypertension or pulmonary venous hypertension in a way, giving a pulmonary vasodilator, is it harmful? Now, I appreciate this is not a pediatric study. This is an adult study. Essentially, they recruited adults with LV failure, where they had LV diastolic dysfunction and had pulmonary hypertension. They were randomized to a pulmonary vasodilator against placebo. The vasodilator they used was ipoprostenol. And again, they demonstrated that the group who received ipoprostenol had better effect on pulmonary pressures, but they did much worse from outcomes. So they had to stop the study because the group where they were given pulmonary vasodilator, there was significantly increased mortality. And hence, essentially, this is what their conclusion is, that unfavorable effect of medications may be important than hemodynamic benefit. So they demonstrated that intervention had a hemodynamic benefit, but the hypothesis, it led to more pulmonary congestion, leading to pulmonary edema, and had adverse clinical outcome. And this, the paper that you see on the right side is Neil's paper, where about babies with diaphragmatic hernia. And I've just put the statement that he made in the discussion, which is quite relevant here, that in presence of primary LV dysfunction, excessive pulmonary vasodilation might theoretically exacerbate LV diastolic dysfunction and pulmonary venous hypertension. This may in part explain variable response to pulmonary vasodilator, which is, we are talking more and more about this, but again, the emphasis is that it may not be effective. I think what I'm trying to highlight here, it may make potentially things worse. So learning for the things here for these babies, how to identify these circulations is clinically, both these little ones had a response to nitric. They have been on nitric for more than 24 hours, and they got worse with oxygenation whilst on nitric. And this is despite all the respiratory optimization strategies. And echocardiography, both these little ones had evidence of pulmonary hypertension, but didn't have a suprasystemic pulmonary hypertension. That potentially may help. And they had other physiological abnormalities. One had DUT and one had possibly diastolic dysfunction of LV. And hence, I think my learning here is it's always important to understand the mechanism of pulmonary hypertension. Nitric may not be always an answer in pulmonary hypertension phenotype. And these babies, the response of weaning is very, very fast and actually quite rewarding. But you just need to stand by that, because these babies are very sick. They're at the purge, and you don't want to change physiology very rapidly. This is my last slide. I think I put here relationship of oxygenation and pulmonary artery pressures. We always think they are mutual, that as you improve your pulmonary artery pressures, your oxygenation should get better. I think that's the case in most of the circulations, because most of the circulations, the pulmonary hypertension is driven by pulmonary vasospasm. Hence, as you improve your pulmonary artery pressures, your oxygenation gets better. But on the other hand, if you have this type of physiology where actually it is driven by pulmonary venous congestion or because of increased flow, you may improve pulmonary artery pressures because that's what the drugs are meant to do, but your oxygenation would get worse. I think I'm going to stop there. Open to questions if you have any.
Amazing cases, and I thank you very much for sharing. So we'll just open the floor for questions. I'm sure you get plenty of questions. Is that Andre's hand?
Hello. Yep, it's me here. That was an absolutely lovely presentation. Thank you. And as you'll know, working with Neil, it's a subject quite close to our hearts. And I must admit, I've seen a lot of very preterm babies that I sometimes think present with that similar pathophysiology. You have a huge duct, but you have some evidence of tricuspid regurgitation and mild right-sided impairment. But actually, it's almost certainly a kind of post-capillary shunt-driven pattern, which it's really nice to hear someone else talk about that and have observed that, because I suspect we'll all find cardiologists kind of poo-poo that idea. Whenever they see a big duct, they say it's not significant because you've got some right-sided dysfunction. That's the problem. Can't be significant. So I think that's really interesting and beautifully put. In fact, we've gone on to write a kind of, it's still in its infancy, but a sort of pathophysiology-driven flowchart of the different types of pathophysiology and underlying echo findings you might find and suggested treatments. And one of them certainly pulmonary hypertension type that's post-capillary. And one of the comments is may not be a nitric responder, but maybe it should be, we just shouldn't put nitric on. It's interesting. I had a question though. The babies with congenital diaphragmatic hernia, have you any idea of what happened to suddenly change things?
What changed?
Yes, from it being sort of, what suddenly tipped the LV function, do you think?
Oh, I don't know. I mean, we this kid hasn't had an assessment every day. So essentially, he had an assessment after coming. At that time, I think the focus was, is this structurally normal heart as a part of a congenital anomaly? And as normally we see in these babies had pulmonary hypertension. But unless they're progressing well, we don't tend to look every day for hemodynamic assessment. I think that's what probably happened. Coming back to your question, I don't know what pushed. I think LV probably was. I don't know is the answer, but there was definitely a clinical change which had happened over 6 hours in the evening, where this kid was in 50% inspired oxygen, and the team had just been going up on pressures, including on inspired oxygen.
Yeah.
And as you saw, actually the chest X-ray at that time looked so much better as compared to the X-ray that was there at the time of birth.
I mean, it really does make the case for looking frequently, doesn't it? Either after you start nitric or patients like this. And just, I'm sure other people have got lots to say, but I'd just be interested if anyone wants to come back later at, I think this idea of LV dysfunction is something we need to look at much more. And
Yeah.
I'm intrigued when I look at some of the literature coming particularly from Japan with their preterm babies about using many more vasodilators early on. Nitroglycerin, they're very focused on systemic vascular resistance and LV dysfunction, which seems like a big step to take. So I'd just be interested if anyone else has looked at that or got comments on it in their management of babies.
I mean, having spoken to a colleague who is interested in pediatric but works in the adult, he's an adult cardiologist and runs cardiomyopathy types service, inherited cardiac conditions. And having spoken to them, he said even if you have a diastolic dysfunction, your pulmonary pressures will be improved by pulmonary vasodilator. I think if the clinical aim is to reduce the pulmonary pressures, that should not be same. That will not be same as improving oxygenation. Because you may improve still the pressures, but it would lead to venous congestion and pulmonary edema type of picture, and you will get worse from oxygenation point of view, which is, I think, what happened in the second case.
That's very interesting. Thank you.
Thank you.
So, Anay, can I ask you a couple of questions, please? So, so I mean, that's really fantastic because you managed your approach based on the pathophysiology rather than just a regimented approach, which is probably what we all need to move towards now. So in terms of the LV dysfunction, it's becoming more kind of well recognized in publications nowadays, and there are quite few. I don't know if you came across, there is a nice article by Satyan, When to Say No to NO. I don't know if you've seen this one. Yeah, so he described beautifully the LV dysfunction phenotype and post-capillary pulmonary hypertension. And I wonder if you have used or thought about using pulmonary venous Doppler to guide you, because you know when you start before nitric, it will have a certain velocity. After nitric, it will probably double, and that might sometimes give you a clue if there is no response and the increased venous flow. That it's already what you're talking about, the pulmonary venous congestion or flow-driven pulmonary hypertension rather than a resistance type thing.
I mean, the question is whether you would start nitric at all if you have a diastolic dysfunction. I think the problem is a lot of things are driven clinically, that if you have someone who is saturating in low 80s, you've done everything you can't, and nitric is put as a desperate measure when you're, pushing against the wall. I think coming back to your question, if I were to see diastolic dysfunction and I have a hypoxic child with evidence of pulmonary hypertension, whether I would start nitric or not, I probably would, but keep very close eye on that with repeated hemodynamic assessment is what my view would be. And
for the dopamine, I know it's a very controversial topic, but have you thought that sometimes, dopamine, so dopamine is mainly actually vasopressor rather than inotropic support. And the problem, it has also effect on the pulmonary venous pressure. So as it increases that systemic vascular resistance, it also increases pulmonary vascular resistance. Have you thought about trying something different, or that's what you feel more comfortable with?
I think dopamine is, again, as we talked last week, it's a vasoactive drug that staff is familiar with, including people who do not routinely scan, and that's the first drug that gets started, and usually it's not following a formal hemodynamic assessment. So for this child, we weaned dopamine very fast and stopped actually. And the baby then just was on milrinone and small dose of NORAD, which then was weaned.
Okay, perfect. My last question, the X-ray you presented for the CDH baby, was there a fusion on the left side? Because I wonder if you...
No, so this we see very commonly.
Yeah, I mean, have you tried the lung ultrasound on that?
No, I didn't do it, no. Okay. Let me just bring the X-ray back. Can you still see the slides?
Yeah, this one.
Yeah, no, I haven't looked for the lung ultrasound that side, but there was relatively well expanded lung on the left side. And as soon as this physiology changed, this child, went home within 10 days of that X-ray.
Okay, Grant. Thank you very much.
I think Bikash has his hand up. Bikash?
Sorry, can you hear me now? Sorry, my audio was mute. Thank you, Anay. And I echo, as everybody has said, really lovely case presentations with the physiology-based approach. And this is what message I try and give to my trainees and colleagues is that please do not jump on to start this nitric oxide gas. What we have come to the stage where we start nitric oxide as soon as we see a baby has any evidence of PPHN without thinking much of physiology. And nitric oxide is one of the medicines which we start at higher dose and then decrease it, rather than other medicines when we generally started at lower dose and then built up the dose. Like most of the medicament, nitric oxide, we start at the high end, bring to it. And particularly for case number 1, it was very evident that despite of, you had a good TR going on, but at atrial level, I could see the shunt was all left to right. Am I right? In the first case, the preterm babies,
so even on the ductal Doppler, the gradient was around 15.
Yeah, so and you can see the rate to that again, which made you must have thought about more of a overflow physiology rather than a spasm physiology. So my question was to the group and to you also, what in terms of the diastolic dysfunctions, what are the most reliable hemodynamic assessments you guys find? So I've started doing a lot of MPIs now on tissue Doppler, and sometimes I get the numbers which, first of all, we have this subjective assessment tool when you do echoes for so many years. Just by eyeballing, you get a decent idea what you're dealing with, and then you try and corroborate your subjective assessment with the objective parameters. And I don't know what people's thoughts are in terms of the MPIs in tissue Dopplers when you start doing it. Because it's a very objective parameters. When you put a ECG lead there, you should be able to see the ICT and IVRT very, very clearly with the contraction time. I should get the numbers. And other thing is your for RV, how many of you reliably think FAS is because again measuring areas in right ventricular, which is a semilunar structure wrapped around LV. How reliable you find using FAS to predict RV dysfunction? So those are my 2 questions in using this.
Can I answer this? So essentially for, practically, as far as the times are concerned, so IVRT, elation time and things, I try and avoid using time because there has to be heart rate correction to them. A lot of these kids would be on different vasoactive drugs, could be firing at 190, 180. I think I personally find tissue Doppler, ENA wave prime, as well as pulmonary venous Doppler interrogation as most reliable. I don't tend to use the absolute time as one of the measures.
Yeah, I was talking about MPI on tissue Doppler only. I'm not talking about the. So that's what I do. I don't do just the tissue Doppler, IVRT, and ICTs.
Yeah. So tissue Doppler, even tissue Doppler would be influenced by your heart rate. Your IVRT will change, I think.
But then your diastolic function is you're measuring diastolic function considering
then,
whatever heart rate it is.
The question is, if it is heart rate dependent, how do you standardize it for different physiology for someone who is on has a heart rate of 100, someone who has heart rate of 190? As against EA wave interaction, I think in my personal practice is quite very well reliably reproduced. And even pulmonary venous Doppler, I don't have the image here, but had a massive D wave on the Doppler interrogation. So those are the 2 things I personally use.
And what do you do in pulmonary venous Doppler? SD ratios?
SD ratios. Just sometimes eyeballing helps as well. I don't. You can measure, but and it's quite rare for me to see for us at least to see a EA ratio, prime ratios as well as S and D. They go together. They always look similar. I think the issue is presence of diastolic and absence is quite easy. I think the degree of severity is what I struggle with sometimes. I don't know what other people practice.
Yeah, just a quick comment about that. I use the same as you said, but I also sometimes use the TI index or the MPI, but I don't take it as a single measure. I use it serially to see the response of treatment. If that makes sense, because one single reading is not going to tell you much, but you just need to see the response of what you're doing.
Yeah, I completely agree with that. And that's what probably most of us do. But But in terms of the we got normal ranges for myocardial performances indexes, and I personally think it is what the current diastolic dysfunctions measurements we have. Tissue Doppler would be the most reliable ones in terms of comparing to. I mean, even for IVAT for the PDAs, I now use the tissue Doppler rather than the mitral valve inflow IVRTs, which I do on the. So I more depend on these. And the second thing was about the what about the FAST? Do you interpret more reliably than the TAPSEs, or because the cardiologists would vouch on TAPSEs, and they all their long-term follow-ups, even for TOF post repairs, cardiac functions, univentricular heart, they go for TAPSEs rather than FAST.
No, I use TAPSE. It's quite easy to do and reproducible.
Does anybody else use FAST over here?
What can you elaborate what is FAST? Because
FAST is, sorry, fractional area of
Fractional
change.
area of-
Fractional area of change on the
right. FAC, yeah,
RV
yeah.
FAST.
Yeah,
That's what I would say actually.
Yeah. Again, I used it occasionally. It depends how good you're gonna get the views for that. Sometimes you just cannot get the full right ventricle.
That's right.
Or full left ventricle, especially in CDH. So it depends really on the situation, but I don't use it very kind of often, if that makes sense.
Yeah, thank you.
Thank you.
Anay, can I ask a question?
Yeah,
so, so it's not directly related to what you're teaching today. The lung scan, do you routinely couple the lung scan with your hemodynamic assessment? I just felt there was, I mean, you didn't mention anything about the lung cancer. So I'm just curious that when you go in, is it just the heart you would do, or is it more of a focused sort of assessment?
Yeah. So I think as far as my expertise and learning curve is concerned, my cardiology and line ultrasound skills are years ahead of my lung ultrasound skills, I would say. So I do use them. I don't use them as in terms of, I don't formally report as yet, just because I want to build the skills up. But it's a useful tool. So short answer at the moment, I just use it, but keep it to myself for my understanding, rather than using it for service. Obviously, the effusions and the straightforward ones, pneumothorax, they are easy to see. But if you're saying talking about kind of lung expansion or lung or in diaphragmatic hernia, no, I don't have enough experience in that, so I don't tend to.
Okay, thank you.
I think the problem with these ones is when these both babies were sick, and when I started touching nitric dial, the people just felt that I was unsafe to do. So I think that's really key to try and so nursing staff were very anxious as this baby was in 100% oxygen. How can you go down on nitric? Because it's quite fixated in mind that nitric equates to better oxygenation. But when they saw as we came down on nitric, the oxygenation improved. Was a big change, and then following that, then few practice educators came to ask you, can you just explain why you did and what we did for our understanding. So I think it's again there's lots with, especially with these ones, about education and training, not just to nursing staff but the colleagues as well.
Yes, I was just wondering, so alveolar recruitment is something, I mean, as you adjust the ventilation settings, especially with the gut in the chest and the X-ray not really helping you with, it's a static one-time view. So you can actually really nicely monitor alveoli opening and the extent, and you, as somebody like that, it's very reassuring to keep seeing that you haven't. There's no air leak. So I was just curious. Are you
so we were just actually starting a so the lung recruitment validation is in neonates. I think there's only one study that looked at how best objectively. I mean, there are lots of studies from adult Fusic Word where they use your PEEP based on lung ultrasound score. So we've just started. So we routinely use neurally adjusted ventilation assist on the unit as a mode of support of ventilation. And we're just starting to recruit in a couple of months to look at lung recruitment pre and post NAVA initiation. So we'll probably get more experience following that. But yes, it's useful too.
Because you have a question or the legacy hand?
So sorry, that must be a legacy hand.
Okay. Any other questions? Actually, we would like to welcome new colleagues who joined today. So we have Susanna, we have Aaron and Anupam and Kirti, Sadav, and we have also Almudina Alonso, who is a world expert in lung ultrasound. So we're looking forward to hear from you soon, hopefully.
So Aaron's hand is up.
Yeah, Aaron.
Yeah, just a quick thing. It's nice to see you, Mahmood, Bikash, Anay. We've all worked together, and it's fantastic to see
Gosh,
you.
you look much more younger than what I looked 10 years ago.
Thanks, Anay. Now, my question is something slightly different. It's Anay, it was a wonderful presentation, I have to say. Fantastic. I really enjoyed it. My question is something slightly different. I'm slightly confused after attending this BCCA meeting, which I did very recently. And I think the particular session on pulmonary vein stenosis, I think there was some interesting talk about it, that pulmonary vein stenosis doesn't necessarily have to be anatomically driven during the fetal development. It's something which often develops with in babies where there is a large left to right shunt. And apparently, if there is a pulmonary overcirculation because of a congenital heart problem, be it PD or VSD, whichever heart condition which leads to pulmonary overcirculation because of left to right shunt, the blood apparently flows through the pulmonary veins, and due to the shearing stress, the pulmonary vein stenosis can happen. And interestingly, one of the things that came up also was the fact that when we see the babies who are basically stuck on the ventilator on chronic lung disease, developing pulmonary hypertension, often what we see is they are not responsive to the nitric as much as we expect. And one of the things that is coming up is these babies should have the pulmonary venous anatomy looked at again in the view of persistent left to right flow because of the pulmonary overcirculation for months, and probably develops pulmonary hypertension as a consequence to the excessive blood flow through it. I just wanted to ask the panel, what are your thoughts on that? Because my understanding about nitric and all is it's a vasodilator, but it will probably work on the pulmonary arteries rather than pulmonary veins, because pulmonary veins doesn't have the smooth muscles. So what are your thoughts? This is a question to the whole panel. Thank you.
Thanks, Aaron. Anay, would you like to?
Yeah, can I just a couple of points? I think P.S. Daubeny from Brompton actually published, to my knowledge, a largest pulmonary vein stenosis series. This was published, I think, 6-7 years ago, and the 1/3 of that population was extremely preterm babies, and a lot of those babies, I can't remember exactly the numbers, had a left-sided lesion, so left pulmonary venous, typically superior stenosis. And his feeling was, though duct inserts into main pulmonary artery, the blood flow preferentially goes to the left pulmonary artery, which comes back to left pulmonary vein, which is what leads to intimal tear or shear forces leading to stenosis. I think coming back to your question, so that's something which here we routinely see before starting sildenafil, because you're right, it's like giving ACE inhibitor to someone with renal artery stenosis. One could argue that pulmonary hypertension is a compensatory effort taken to push blood through a blocked passage. And I spoke with Shahin Molidana as well. He's a pulmonary hypertension guy at GOS, and they're quite hot on pulmonary vein stenosis. And unfortunately, echocardiography is not a very sensitive method of diagnosing it. It has an intervention, but has a very high recurrence risk. And his view was that all of them should have a CT to rule out pulmonary vein stenosis before commencing on pulmonary vasodilator, which is aspirational. But these babies, you can't get CT on. They are on unit, ventilated, high inspired oxygen. So yeah, that's just a comment.
Thanks, Anay.
So this is an interesting question, actually, Aaron, and we've seen a couple of cases like this that we actually were struggling with. And I'm going to share one case that X24 Waker had a couple of DARTS courses, and then once was stuck actually on CPAP in 50–60%, and we were trying to avoid really intubation. So we tried to give him sildenafil, right? And all the echoes done just to look at any pulmonary venous stenosis were kind of normal. And pulmonary venous stenosis can develop later on in life. So don't take the first echo was normal, then there is no pulmonary venous stenosis. You have to look every time. So when we use sildenafil, I combined that with lung ultrasound score and lung NIRS actually, and the lung ultrasound, so the NIRS improved after sildenafil because it's pulmonary vasodilator, so it will increase your blood flow. It makes sense. However, the lung ultrasound scores increased and the baby oxygen requirement increased because it was not a problem with pulmonary hypertension. It was a problem at the alveolar vascular interface. So i.e. it's fibrosis, inflammation, rather than pulmonary hypertension. So that baby responded to steroids actually. So we had to stop quickly the sildenafil and oxygen start to come down. And when we started steroids, we could wean him from CPAP. So it's not always the pulmonary vasodilator is the answer for those babies.
Thanks, Mahmood.
Bikash and Anne-Marie?
I'll let Anne-Marie go first. Her hands were before me.
Okay. Yeah, I think, Mahmood, you've made a nice point that for those babies, the pathologies can often be quite mixed. But Aaron, I think what you're presenting really resonates. I've been doing all of this for too long. Quite a number of years ago, I had a trainee presented a series of cases, extreme preterms with later onset pulmonary vein stenosis. They were thought to have severe chronic lung disease, but when they were worked up and the outcome was, yes, they do require a CT, they had significant pulmonary vein stenosis, but it's extremely difficult to manage and it's got an awful outcome. So I just wondered, from the cardiologists at the BCCA, did they express any view of, therefore, the potential harm of very small babies, very preterm babies, sitting with prolonged significant ductal shunts? Because you know how controversial it is. But it'd just be interesting to hear what the view was from the other side coming across.
Aaron, are you going to answer that question? Sorry, because you attended the...
Well, it's always, I think, a little bit debatable when we talk about, treating a duct and not treating a duct. I think whenever the question comes up, I think a lot more comes in the picture. But so far as the evidence is concerned, in terms of treating a duct, long-standing duct, the impact of the pulmonary overcirculation on pulmonary hypertension, I think that needs to be categorically teased out, because I think all the studies are so far showing that if you're treating the duct, anticipating these problems, it's actually not changing the outcome. So this is a completely different domain, and I think we need to start looking at the impact of pulmonary hypertension because of persistent pulmonary overcirculation, because of a patent duct which has been there for a long time. Because I think a group of neonatologists, and in fact, with all the evidence that is coming up, people may argue either way. So it's a question, I think, difficult to answer.
It's a great concern because it's such an awful outcome to have. And I'm just not sure that any of the current clinical trials are designed in a way that lets us get at this kind of question at all. But no, it's interesting. It's very interesting. Thanks.
Just for the point on pulmonary venous hypertension, and it comes very much into my case series, which I wanted to present soon. And I've got an interesting case series, which I've been collecting for pulmonary venous stenosis. And interestingly, as Anay mentioned in Piers Dobney's study, that he saw mostly on the left upper pulmonary veins. And I've got the other experience where I've seen quite few recently with right upper pulmonary veins, isolated right upper pulmonary veins. So I don't know whether this is the theory of it is probably much more multifactorial rather than just being the PD overflow. And probably, and as there's a big study and a case study presented in Netherlands, where they, IUGR being a very important factor in babies with underlying, and there are so many other factors, small for gestational age, IUGR, and the developing severity of chronic lung disease. There's so many other factors which are in play. But in most of the cases, and I agree with that, the echocardiography is a very poor sensitivity in diagnosing pulmonary venous hypertension. There is we can miss, particularly the isolated ones. But most of the time, I've seen them, they've resolved by themselves in our case series without needing any interventions. And most of the time when they've needed interventions were in kids who had underlying congenital heart disease type of pathophysiology rather than just an isolated pulmonary venous hypertension. So I'd like to present them in my subsequent one of the meetings in the future, whenever we get a chance.
I mean, and the problem is a lot of these may have a proximal disease, which you will not see on echocardiography. And that's a problem. Getting CT angio in a non-cardiac center to define that there is no proximal disease can be quite challenging in these babies. And the question is then, where do we go? I think a practice we do here is we start them with ultrasound and with echo. And if things were to get worse purely from respiratory point of view, we stop them.
So I didn't get you. You start them on?
So we start them on, so we don't do CT angio. So I mean, because you can diagnose distal disease quite well.
Yeah.
You may have obstruction at the entry, but these babies can have quite proximal disease as well, which will not be seen on echocardiography. And on the CT is a most sensitive way of getting it, which is quite challenging in a non-cardiac center. A, you don't have, well, these babies are sick to go down to CT. B, you don't have enough expertise to try and interpret and look at the pulmonary venous anatomy. And hence, here we just start if there is no echo evidence of pulmonary venous stenosis. And if there is worsening within 2 to 3 weeks time, we wean and stop. And again, our aim of treatment is improvement rather than resolution. I don't know what you use in these babies. Meaning, once we start the dose, we will increase the dose till we see improvement rather than complete resolution.
You're talking about BPD-PH then?
Yeah, I'm talking about BPD-PH as well. Yeah.
Okay, without pulmonary venous stenosis. No, thank you. That makes sense.
That's great.
That's it, isn't it?
Yeah, thank you very much, everyone. And looking forward to your presentation, Bikash, for the pulmonary venous stenosis.
I'm just a bit overwhelmed at the moment, so I'll get the slides whenever very soon. I've got the echo films for them.
That's brilliant. Thank you. Thanks, everyone, for joining today. Have a lovely weekend. We'll upload the recording soon.
Thank you.
Thank you. Thank you.
Thank you very much. Thank you, Anay.
Thank you.